Good morning, Mr. Chairman and Co-Chairman. My name is Putthimet Lekhakul Promin. I'm the fourth-year medical student from Prince of Songkla University. Today, I would like to present the study Somatic Mutation Profile and Potential Genetic Biomarker for Molecular Target Therapy in Thai Neuroblastoma. Neuroblastoma is the most common childhood extracranial tumor developed from neural crest cell. This cancer has a high mortality rate among childhood cancer, according to 50%. Disease prognosis is significantly influenced by risk classification. In the low risk group, 5 years overall outcome is more than 90%, but this is only 50 to 60% in high risk group. Nowadays, tumor mutation profile from previous studies show that ALK, BRCA1, and MEK are reported to have association with the disease. But this cancer can be cured and has well response on conventional therapy such as resection, chemotherapy, and target therapy. Nowadays, we have target therapies such as sirotinib and ceritinib, which are ALK inhibitors. So, understanding these genetic alterations is essential for both treatment and clinical outcome. In this study, we have two objectives. First, we aim to evaluate somatic mutation, including frequency and clinical correlation. Moreover, we also identify potential biomarker for target therapy selection. To achieve the goal, I went to the 5 steps shown as the diagram. We used tissue sample from patients at Songkla Nakarin Hospital who were younger than 15 years of age. During 2003 and 2023, patients who had tumor biopsy with staging were included in the study, and the frozen tissue was drawn for DNA extraction at our biobank. We used tumor-derived DNA specimen from research rare and childhood cancer multi-omic for precision medicine drawn at the biobank Prince of Songkla University. Quality and the quality of DNA were assessed by the nanodrop. Sample with DNA concentration lower than 20 nanogram per microliter and the absorbance ratio was lower than 1.8 were excluded from the study. Totally, we have 45 cases, and the clinical profile of patients were retrieved from the medical data record. To analyze the somatic mutation profile, whole exome sequencing was proceeded using a giant preparation protocol, and the result FASTQ file were aligned with human reference genome using the Borrow-Wheeler alignment program to create the sequence alignment map file or SAM file. The SAM file will also convert to the binary alignment map file or BAM file, and the duplicate sequence were marked by use to resulting the radio read file. And we also use the tumor-only mode MUTEC2 with a panel of normal and the frequency from the public GATK data to identify genetic alteration and variance filtration for each sample, and BAM file to creating the VCF file and the map file in the R program to analyze. All mutated gene and type of mutation and frequencies were reported as an oncoplot by the MAP2 in the R program. And the clinical characteristics, including metastasis at first diagnosis and tumor recurrence, were correlated with the somatic mutation and compared with the feature axis. The p-value which less than 0.05 was considered significant. We also identified the target therapy by using cancer genome interpreter database or the CGI. Let's see the result. From the 45 cases, most patients are over 18 months of age, and 42 patients present with the metastasis at first diagnosis. Bone marrow metastasis and liver metastasis are common metastasis site in this study. Half of these patients show good response with chemotherapy. However, there were 4 cases that interesting would have tumor recurrence. And let's see our oncoplot. This oncoplot presents top 20 genetic alterations identified. The left side of the diagram presents a mutated gene, and the right side represents the frequency of each gene. And the color box at the bottom shows the type of mutation. And the green one refers to the missense mutation, and the black one for the multi-hit mutation that are common in this study. In this study, KMT2C, RUNX1, and MEK oncogene alterations are top 3 mutated genes that provide 90%, 70%, and 60% of patients respectively. And this table presents association between mutation and metastasis and also the recurrence we found in this study. Many genes more likely to have no metastasis at the diagnosis. And for the recurrence group, we found 4 genes, including O1RN1, ATRN, POTF3, and also the BRCA2 in all 4 cases. And this table, according to the CGI, we found 2 driver genes having target therapy overcoming this cancer. And the first one is LRP1B, which is the LDL receptor. And it has liposomal doxorubicin as target therapy. However, CGI revealed that At the present, this target therapy has a well-performed on other cancer. And the second one is neurofibromatosis type 1 or NF1 gene alteration that have multiple target therapy, such as the sirolimus, everolimus, traneximab. And moreover, the retinoic acid should be prioritized in neuroblastoma patients with NF1 mutation. Let's see to the discussion and conclusion of this study. The discovery of somatic mutations such as KMT2C, RUNX1, and MEK provide valuable insight to neuroblastoma tumor development. And the RUNX1 and other mutations such as NF1, TRT has also previous reports on case study and cohort in both Western and Asian population. This mutation profile can support or clarify that they are significant to neuroblastoma. And also, MYC mutations found in this study also need further research on the survival and clinical outcome. And the potential target therapies based on driver mutations such as LRP1B and F1 mutation is also promising. However, the diagram shows the target therapy in the recurrence group. The molecular target therapy in all 45 patients need further progress. And the clinical efficacy of these identified markers need to be further validated. And also, further research with the larger cohort of the recurrent case for identifying mutation and validation, and the recurrence biomarker development should be considered. Thank you for your attention.
Surely this presentation inspired us all. Does anyone need any comments or any questions?
Is the genes you found commonly mutated in the Thai sample similar to what have been reported elsewhere?
The report on the Western population, the older Asian population, and the Korean and the China population also have TRT and F1 mutation and also MEK. But we have the interesting point that we found the MEK mutations in this study. That should be considered because we have a report that MEK amplification have significantly to the severe neuroblastoma or the metastasis, and also the M spatial stage of the neuroblastoma. So discovering of MEK mutation in this study should be prioritized or have more research about it.
So I also saw that you did not have any match normal when you study the variants. Would that be contributing to any problems or the difference?
In this study, we used the panel of normal of GATK public data, but it is undeniable that this public data is based on the Western population. So another way to improve this research, we have to use the public data or the open data source from or genome data from the Asian population or Thai population.
Does any judges need more clarification? Thank you very much.